So we'll touch here on one of the overgrowth syndromes that you're going to be responsible for knowing for the USMLE, and that is Sotos syndrome. The other one is Beckwith-Wiedemann syndrome, and there's some pretty distinctive features that separate the two of these. So hopefully by the end of this, you'll kind of have an idea of that. Sotos syndrome is also known as cerebral gigantism, and the reason for that is because not only is there an overgrowth, these babies are large for gestational age, and there's a really significant growth during the first few years of life, and these children during elementary school age years will tower over their peers. But not only is there that overgrowth, but there's also this very distinct overgrowth of the head. And you can see that there's some pretty significant frontal bossing on this child. Sotos syndrome is also characterized by a prominence of these facial features, and it's actually these distinctive facial features that are the most specific finding for Sotos syndrome. It has the highest correlation with a positive diagnosis. And so some of the things that you notice on this child include these very, very sunken eyes, sort of a pointy chin. So those are things you'll look out for. There's some other things too. These facial features tend to become a little bit more prominent during childhood and then into adolescence. They also tend to have some neurobehavioral features. Most will have some level of mild mental handicap. The range, though, is really broad. So the IQ range has been reported anywhere from 40 to 129. So that's a really, really big range. On average, though, these children tend to have an IQ of about 76. So not to the point where it's going to cause huge issues, like maybe something like Angelman syndrome, but it's enough to where it is tends to be a clinical finding of significance. They also can have some behavioral issues, such as autism, or they may have features of autism. And ADHD tends to be present as well. The incidence is estimated between 1 in 10,000, 1 in 14,000, so this is pretty rare. And the genetic site of interest here is the NSD1 gene, which is found on chromosome 5 on the long arm. And this is actually responsible for more than 3/4 of Sotos syndrome cases. But there are cases where Sotos syndrome is diagnosed because it's primarily diagnosed clinically, where this is not the gene of implication. So NSD1, that gene codes for a histone methyltransferase, which is involved in transcription regulation, and this gene actually happens to be expressed in a lot of different tissue, and so this is why this affects so many different organ systems, and is also plays a role in growth too. Most cases of Sotos syndrome are sporadic, so they're due to de novo mutations. However, if it is inherited, it'll follow an autosomal dominant pattern. So if a parent has Sotos syndrome, their child will have a 50-50 chance of getting Sotos syndrome. So these are the features that you'll see. The ones in red are the ones that, in my opinion, are probably going to be the most likely to come up on the USMLE. So, of course, they're large for gestational age. Their length tends to be a higher percentile than their weight, though. Macrocephaly, early feeding difficulties, and this can actually necessitate tube feeds in about 40% of patients. So you can have early feeding difficulties, and this can lead to dehydration or failure to thrive. Neonatal jaundice is another feature, and that can either just be due to the Sotos syndrome itself. It can also be due to breast milk jaundice or breastfeeding jaundice. Profound growth in the first 2 years of life, but really these children will grow much faster than their peers for quite a while, up until about 12, 13 years of age, and then that's generally when they hit their adult height. So they level off. I'll show you a growth chart, and you'll see how different it is from a normal child. Their facial features, you'll want to know this because these facial features are the most specific finding to Sotos syndrome. So the frontal bossing, which we saw in that baby, they tend to have a pointed chin, a much more prominent jaw. They can have some degree of hypertelorism. They have what's called anti-mongoloid slant, and so this is down slanting palpebral fissures. Anteverted nostrils, we saw that in that baby right there. Well, not too prominent, but the nostrils tend to be uh, uh, flexed upwards. And then malar flushing and premature fontanelle closure. Skeletally, musculoskeletally, hypotonia is a very prominent feature, and this is going to lead to a delay in their gross motor milestones. They also tend to have an advanced bone age, and that just reflects their growth. Uh, like I mentioned, they tend to have learning difficulties, but certainly not all of them will have that. Uh, they will be delayed developmentally, though, like I said, with the motor delays, but they also tend to have a pretty prominent speech delay. It's not unusual for them to go up to 2.5 years without saying a whole lot of words, but this will generally pick up a little bit later on. About a quarter of these patients will have seizures. They also tend to have issues with fine motor skills, so they can have clumsiness and poor coordination, and some of them will have increased deep tendon reflexes. Like I mentioned, ADHD, autism can be present. Those autistic features can manifest as social inhibition, aggression. They can also have psychosis. About 10 to 20% will have congenital heart defects. So when you make the diagnosis, you're going to need to have these children screened by a cardiologist. There's also a preponderance of genitourinary abnormalities. There can be issues with the kidney, all the way down to the urethra. And hypospadias is a common finding, but there can also be cystic kidneys, duplex or absent kidneys. And then cryptorchidism is something that you'll want to evaluate for in young boys. So this is a cartoon of boy and girl with Sotos syndrome. You see the very prominent head, frontal bossing. You see that very pointy chin as well. So this is two children, a 3-year-old and a 12-year-old with Sotos syndrome. You see the in this 3-year-old here, you see this very, very large forehead. If you were to look from this side, you would notice the frontal bossing. You also can see these sort of puppy eyes, these downward slanting palpebral fissures. So here's another child. Again, you see this very prominent forehead. Now remember, with any dysmorphic disease, with any of these genetic disorders that have abnormal faces, you're not going to see every single one of the features in any one patient, and so it's really variable. So you're looking for a constellation, but you're not necessarily going to see all of them. So here you see this child. You can definitely pick up on the hypertelorism. His ears are a little bit larger. He's also got a very prominent forehead, and then that pointy chin here. So here's a growth chart starting at age 5, going on to 20. And you can see that this child who had Sotos syndrome continued to grow up until about age 12. He really started to level off. And so by age 14, he really had reached his adult height. And that's not where you should stop growing. Usually most boys will attain their adult height by age 16, 17, 18 years old. So you can see that even though this child was tracking well above the 98th percentile, all the way up until about age 12, 13 years old, he actually wound up in about the, I'm not sure what percentile this is, but it looks like it's about like the 60th percentile. So most of these children will have their normal predicted adult height, but during childhood they'll be taller than usual. So this is Sotos syndrome both in children and in adults. You can see that even though they do attain normal adult height, their growth slows down, they do retain their facial features. So you can see that this man quite clearly has a pointy jaw. He's got slightly bigger ears. The frontal bossing isn't as prominent in adults just because they sort of become more proportionate. But definitely that jaw is you can really pick up on it both in this woman and in these two men. Developmentally, of course, their physical development will be affected by that hypotonia. They can have early feeding difficulties, which can lead in failure to thrive, and that's going to necessitate a feeding tube in about 40% of patients. Of course, when to put the feeding tube in is just going to be based on whether or not they've responded to changes in their nutritional habits, but that's another issue. Hypotonia is going to delay the gross motor milestones, and then children often track above the 98th percentile up until early adolescence. Cognitively, the average IQ is 76, but has a very wide range. There's characteristically a delay in speech acquisition. Children also will struggle with stuttering, and they tend to speak in this very low, monotonous voice. So those speech features are pretty unique to Sotos syndrome, which will really separate it from Beckwith-Wiedemann syndrome. There's also an association with ADHD, as well as these autistic features that may or may not be present. Adolescent and adulthood, really, this kind of starts to go away. I mean, you're born with Sotos syndrome, you always have Sotos syndrome, but this is really a disease of childhood. So because their growth stops early, these children usually attain normal adult height, and there's really not a whole lot of implications in adulthood besides what was there during childhood. So if they had mental retardation, or if they were lower in that IQ range, then of course, yes, that's going to affect them during adulthood. If they had seizures during childhood, then yes, that can go into adulthood. But for the most part, the issues with growth and this, fast growth rate, that's stop during mid-adolescence, and there's no increased cancer risk in that sense, in contrast to Beckwith-Wiedemann syndrome. The differential, so only 2 of these I believe you're going to be responsible for on the USMLE, but I wanted to include 2 other syndromes that are considered clinically relevant. But Beckwith-Wiedemann syndrome is probably going to be the one that this is compared to the most, because you're going to be responsible for knowing these 2, and they're both more common than the other overgrowth syndromes. So Beckwith-Wiedemann syndrome, what sets this apart is that it features hypoglycemia during the newborn period. Beckwith-Wiedemann syndrome also tends to have macroglossia. That's a very characteristic feature, as well as either umbilical hernia or omphalocele. And Beckwith-Wiedemann syndrome involves the IGF-2 gene, which is found on the short arm of chromosome 11. Weaver syndrome is more rare in comparison to Sotos syndrome, but it does share similar features, and it's often confused with Sotos syndrome. For the most part, if you see a child that looks like they have Sotos syndrome, they probably have Sotos syndrome since it's more common, but there are some features that will separate Weaver syndrome out. These children, their jaw tends to be in a posterior position, so it's called retrognathia. They also tend to have a smaller jaw and then a wide philtrum. I don't think you're going to be responsible for knowing about Weaver syndrome on the USMLE, but I included it here. Simpson-Golub-Bemmel syndrome is relatively important for clinical practice because this is an X-linked recessive disorder. That's going to actually help you because this is seen in families, whereas Beckwith-Wiedemann syndrome and Sotos syndrome, these are sporadic diseases. So this is an X-linked recessive disorder, therefore it's going to be seen primarily in boys who have a family history of similar problems on their mom's side. Similar features are seen in SGV syndrome as what you would see in Beckwith-Wiedemann syndrome, in as much as there's a newborn hypoglycemia, large tongue, umbilical hernia, omphalocele. But with SGV syndrome, unlike Sotos syndrome and unlike Beckwith-Wiedemann syndrome, you see this abnormal face, and it's much different looking from Sotos syndrome. You see a very wide nasal bridge, prominent jaw. They call it a bulldog facies. So Weaver syndrome looks like Sotos syndrome more so, but with Weaver syndrome, you'll be able to differentiate it based on the fact that with Weaver syndrome, there's a retrognathia and a micrognathia. And if you just Google Weaver syndrome, you'll see what I'm talking about. SGB syndrome is more similar to Beckwith-Wiedemann syndrome, but with Beckwith-Wiedemann syndrome, you don't typically have an abnormal facies. With SGB syndrome, they have this what's called a bulldog facies. And like I said, it's X-linked, so that's going to help you differentiate it out as well. Fragile X syndrome is not an overgrowth syndrome, but there are some similar features to Sotos syndrome. So this is an X-linked dominant disorder with variable penetrance. You're going to see it since it's X-linked dominant, X-linked in general. You're going to see it more in males. There's similar facies to Sotos syndrome in as much as there's a broad head and a long face. You also see an intellectual disability with Fragile X, autistic features, social inhibition, but the one big thing, you probably know this if you've watched my lecture on Fragile X syndrome is not associated with overgrowth. That's not a feature of Fragile X syndrome. But you can see that there are some similarities as far as the neurobehavioral effects, and the face can look somewhat similar. Diagnosis of Sotos syndrome is primarily going to be based on the clinical examination, developmental assessment, and bone age radiographs. The facial features, the facial gestalt, is the most specific criterion for the diagnosis of Sotos syndrome. There is diagnostic tests available using fluorescent in situ hybridization, but generally this diagnosis is presumed clinically. Once you make the diagnosis, you want to screen for some of these associated anomalies, which include issues with the GU system. So you'll want to get a renal sonography. You also want to get a pediatric urology consultation. These children will typically be evaluated for a vesicular-uteral reflux, so they'll get a voiding cyst urethrogram. You'll want to get, and just to, as a side, the vesicular-uteral reflux is one of the more common genitourinary complications. You'll get vertebral x-rays because of the association with scoliosis, but you could probably hold off on those. Doesn't necessarily need to be done right away, but what you do need to do right away is get a pediatric cardiology consultation to look for any possible congenital heart defects. Typically, the more common ones are just like the more common ones that you see in the general population as far as congenital heart defects go, septal defects, patent ductus arteriosus. Genetic counseling is going to be useful for these, for at least for the parents' sake, because there are a minority of Sotos syndrome cases where where it is congenital. Usually these, with the congenital cases though, because it's not a autosomal dominant disorder, one of the parents will have signs or a history consistent with Sotos syndrome. I will say though, also genetic counseling is going to be useful for these patients as they get older when it comes time that they may be reproducing. Complications of Sotos syndrome mostly are going to be during the neonatal newborn period and during childhood. So failure to thrive may necessitate temporary tube feeding. These children also have some issues with gastric reflux, so you'll want to manage that medically first, and surgery is only a last resort. So some of the things, some of the strategies as far as reflux disease in children, just make sure that you're feeding them upright, keeping them upright for a little while after they've finished feeding. That can be useful. Elevate the head of the bed at night. Occupational and physical therapy are useful for getting around some of those motor milestone delays. Psychotherapy is useful for behavioral problems, and then these children should have special education for any learning difficulties that they might have. Long term, as I mentioned, Sotos syndrome is primarily an issue of childhood, and as growth slows, patients will attain a normal adult height in most cases. Medical complications during childhood can continue into adulthood. Primarily, that's going to be like seizures, psychiatric diagnosis, renal problems, or undiagnosed congenital heart defects, although you should be getting that cardiology consultation as soon as they're diagnosed. As for any child with learning disabilities, IEDs are useful for these children when they're in school, so you can maximize their cognitive development, and that'll help optimize their adult potential. And many to most adults are able to lead normal, independent lives. They are also able to reproduce, and that's going to be why it's important that these patients get genetic counseling, because they will have a 50-50 chance of passing on their Sotos syndrome to their offspring. So if you have any questions, go ahead and let me know, but I will see you next time.